Good evening. My name is John Moy, Senior Director for Policy. Welcome to the Urban League of Greater Atlanta's Health Webinar Series. On behalf of President Nancy Flake Johnson, we are so glad that you could join us this evening for this critical conversation about building a healthier and more equitable future for our communities. At the Urban League, our mission is to empower families and communities, and we know that health is a cornerstone of that empowerment. The data from the State of Black Georgia report paints a stark picture of health disparities we faced. For instance, the infant mortality rate for Black babies in Georgia is more than double the rate for white infants. Even more troubling, the maternal mortality rate for Black women is disproportionately high, with a rate of 48.6 deaths per 100,000 live births, compared to 27.2% for white women. These aren't just statistics, they are a call to action. This continuing series is our commitment to providing you with the knowledge, resources, and tools to not only understand these challenges, but to overcome them. We will be exploring everything from maternal health wellness to chronic disease prevention with the goal of empowering you to take control of your health journey. Now, to kick off this important series, we welcome back my good friend and distinguished speaker, Dr. Michelle Nelson, a leading expert from Clayton State University, who will lead the discussion this evening. Dr. Nelson?
Good evening, everyone, and thank you so much for your rousing introduction, my good friend, Mr. John Moy. I'm so pleased to be with everyone this evening as we continue our health series that really takes a critical, deep, and wide, pivotal look at healthcare matters that really matter to all of us. This evening, we're going to continue our discussion about various pathways to better health. We'll be focusing on vaccine hesitancy, preventative care and health literacy in Georgia, and overcoming misinformation. And unfortunately, there's just so much of that floating around. I have two wonderful friends with me this evening, Dr. Glenda Francis and Miss Janelle King. Dr. Francis is a transformational healthcare executive with Wellstar, with more than decades of experience leading system-wide operations. And Janelle King, the incomparable Janelle King, is a nurse educator with extensive professional practice experience in ambulatory and nursing, working in clinical research. They're going to give you more information about the pivotal transformational work that they do. I'd like to start with Dr. Francis. Good evening, Dr. Francis. How are you? And please share more about
Good
your
evening,
healthcare
Dr.
journey.
Nelson. It's a pleasure to be here. Good evening, everyone. I'm honored to join you today for this important conversation with the Urban League of Greater Atlanta. My name is Glenda Francis, and I serve as the Director of Operations for Community Health and the Center for Health Equity at Wellstar. At Wellstar, we believe health is more than what happens inside the hospital. It's shaped by the neighborhoods where people live, the food they have access to, the ability to afford preventative care, and whether they feel safe and supported. So the Center for Health Equity was established to address those issues, what we call the social determinants of health. Our goal is to reduce health disparities, build community partnerships, and create opportunities for every individual to thrive in mind, body, and spirit. Through initiatives like our community-based programs, partnerships with organizations such as Wholesome Wave of Georgia and GoodR, and events like this one today, we are working to advance equity, close gaps in care, and build trust where historically mistrust existed. So I'm grateful to be here with the leaders and community voices who are equally passionate about tackling barriers to health and wellness across Georgia. Together, we can help shape solutions that move us toward a healthier, more equitable future. Thank you.
Now, Dr. Francis, I feel like I don't even have to ask a question. You are ready and armed with the information that our listeners, our participants, and our attendees are probably craving this evening. So I can't wait to dig into the conversation. But before we do that, hello, Janelle King.
Good
Janelle,
evening.
please share some information about your healthcare journey.
Thank you so much for the introduction and the invitation to speak with you guys. My name is Janelle King. I'm a registered nurse and have been a practicing nurse for more than 10 years, but my background actually started in public health. I was a public health professional before I became a nurse, and I reside in the space of health education. That's what I do. I love to impart knowledge to not only participants of health, but the public health or professionals, giving them information so that they can make informed decisions about their health.
I want to toot a few horns before we get into our meat and potatoes of the evening, and to really say how proud I am of my nursing profession. We are nursing professionals this evening, and it is incredible to see that although we are nurses at our core, the wide depth and breadth of experience and talent that we have in so many different environments is just breathtaking. It's inspirational. And one of my favorite deans, Dean Linda McCauley from Emory University, she spoke at a conference that I had a few years ago, and she said to the audience, nurses will save healthcare. Do you guys believe that? Because I know it
Absolutely.
at my core.
Absolutely. Yes, for sure.
So let's kick off our discussion of the evening. And our first question is going to go to Dr. Francis. The topic of this question, Dr. Francis, is healthcare access and economic stability. And this is so much up your alley because your work really centers on how to serve the needs of various communities. So what we want to know is, how does the lack of affordable preventative care services in Georgia contribute to increased hospitalizations and economic instability in underserved communities, of which there are so many here in this state?
Absolutely. And thank you for the question. I would venture to say that preventative care is the front door to health equity. And without it, diseases are detected late, resulting in higher treatment costs and poorer outcomes. The research shows that 1 in 5 adult Georgians is uninsured, disproportionately affecting Black, rural, and low-income communities. I would also say the economic toll is significant because families lose income from missed work due to illness. Hospitals face unreimbursed costs, which result in raised premiums and reduced funds for prevention. For example, a $50 screening mammogram could avert $100,000 plus worth of expenditure for per one cancer treatment episode. This is a significant ROI if you want to look at it that way. Because if you can spend $50 and avoid spending $100,000 on the back end, you almost can't put a dollar value, because that is just so meaningful. So preventative care isn't an expense. It's an investment that pays dividends in health and economic stability. And I will end my comment here for now.
Dr. Francis, one thing I want to pick up on is you talked about cost. A $15 mammogram.
50.
$50 mammogram.
Yes.
Even if it was a $500 mammogram.
Yes.
Could offset a $100,000 price tag. And when we talk about cost, a lot of time we're talking in terms of financial costs, but the burden of being able to save a life, that is the primary outcome here, with the financial cost being a secondary outcome. For instance, one of the hats that I wear as the Region 11 Director for AANP, we engage in a lot of healthcare policy and legislative advocacy. And something that we have been fighting for on a national level is the ability for nurse practitioners to write an order for diabetic shoes. Now, I went to the conference, I think my first conference back in 2008, or it may have been before that. And do you know, back then we were fighting for that same piece of legislation. It is yet to pass. And every year we stand up, we show pictures of people losing toes, how just
Mm.
being able to put a shoe on or get access to a shoe will save a limb. And you would think that it is so cut and dry, but still we fight for the most basic of things. What do you think about that, Dr. Francis? Does that make any type of sense for the
It
communities?
doesn't. It doesn't make any sense at all. And I think I would venture to say it's about power and control. Because even, and I just want to segue a little bit, even I know we have physicians on the line, but just oftentimes physicians want to have total control over everything that happens in the medical arena and the patient care arena. And they don't realize that having NPs that are equipped, qualified to assist them in that role is going to relieve some of the burdens that they now face, allow more time for them to spend with the quality time, I should say, to spend with their patients. And the things that are not as significant allow another discipline to participate. You know, like the NPs ordering medication, and even now you still have in Georgia, you still need a physician supervisor. No, you qualified in your space. You've been to school. You've sat for the exam, were successful, and now you have to have someone totally controlling you, holding your hand, standing over you to tell you you can't do this or you can't do that. And I think the issues we have in healthcare now, a lot of them can be solved by just doing some realignment with some of our programs, allowing some of the other disciplines to have more of a say in what's happening with the patients, to allow just basic care to be rendered by not the physician, but maybe by the PA or the NP, because I think that in itself would provide the necessary time for physicians to invest in patient care. So I think if we start focusing on some of the things, and if we have some physician champions who would, say, okay, guys, this has been going on too long. When I obtained my doctorate 10, 15 years ago, the same thing was happening. People were still struggling for autonomy in the NP space. And now 15 years later, we're struggling for the same rights to practice in a space where we qualified to practice. So I think there are some things fundamentally that need to change within the healthcare system. And we have to have, of course, the support of our physician colleagues. And I just want to say a little bit more about that, just the name in itself. And this is something that actually is a pet peeve of mine. Even in the space, sometimes I have to remind people that doctorate is a terminal degree. No one practice or no one discipline has the total right over that name. And I think we're still struggling. Some people sometimes ask me, well, how should I call you? How should I refer to you? And I mean, Glenda is fine, that's my name. But I sometimes would say to them, when a physician walks in on the unit, do you ask him how he wants or she wants to be called? How he or she wants to be addressed? You didn't ask them that. So why are you asking me that? I am Dr. Francis, and if I choose and I say, this is who I am, then that's the way you address me until I tell you, it's okay to call me Glenda. So this is my pet peeve. I wanted to share that
Well,
with
as
Doc.
long as we are saying, my name is Dr. Francis and I'm a nurse practitioner, then that very clearly sets the tone for who we are, what we do, and the type of care that we're delivering. And at this time, this is the law. And so most certainly everyone is following that. And boy, Dr. Francis came to preach tonight. Let me tell you, let me just throw out these questions because, honey, the thing is getting spicy. Miss King,
You
I wanted
asked,
to
so I
add,
you asked, so
what
I
say
told.
you? Because listen, the one thing that
yeah,
I want to say before I flip over to you is in the state of Georgia, we do still have a collaborative protocol agreement.
mhm.
So at the end of the day, we're only able to do these things if a physician allows us the privileges to be able to do that. But that's the key. We're trained, we're already willing and able workforce to be able to do this work right now. So give us the ability to practice to the highest and the fullest depth and breadth of our scope because it's not hurting us. We're still going to come out. We've got insurance. We make six-figure salaries. The only individuals that are getting hurt by this are the individuals, the patients, and the communities we serve. And most certainly, we want the absolute best for them. Ms. King, your thoughts.
Yeah, I wanted to add to Dr. Francis's point. I think that not using PAs and Ps, what they consider mid levels, is a disservice to communities, especially when it comes to primary care. We know that in Georgia, there are not enough primary care providers to begin with, and it gets even worse as you go further into the rural areas. And I think one way to alleviate that is just by allowing our mid-level providers to practice up to their highest degree and their abilities. So, Dr. Francis, I agree with everything you're saying. I've been a nurse for a number of years, not only here, but in Ohio, and it's kind of the same type of debates that have been going on for my entire nursing career.
Mhm. The other thing that we most certainly want to get away from is that term mid-level. And I know people still use that a lot, but I'm going to be very clear in saying I'm not mid anything. There's no one above me and no one below. We are all working to the high, or should be working to the highest levels of our ability, of our training, our education, our certification, our experience to be able to work to the depth and breadth of what we're able to bring to the individuals we are charged to serve. So fantastic, fantastic. And so the other thing that I want to share this evening is that we have poll questions that we are tracking how people respond to these poll questions every single time we have a roundtable of this sort. So, Ms. Kennedy Smith, could you please share the first poll question with us? And we're looking for everyone to respond. Kennedy? Okay, well, we'll come back to the poll question. Oh, and here it is. How responsible do you feel for maintaining your own health? Is that your responsibility? Or is it Dr. Glenda Francis' responsibility to maintain your health? Kennedy, does this close out on its own? I think we've given enough time for our response. Okay, fantastic. Ah, everyone said 100% strongly responsible for maintaining your own health. I do want to acknowledge that our very good friend, Derek Jackson, is on with us this evening. Is there a way that we can see him, that he can ask his question?
Yeah, Dr. Nelson, and just to clarify, it's State Representative Derek Jackson.
State Representative Derek Jackson. Can he speak with us? He has posed a question. As a state legislator, I continue to ask the question of healthcare practitioners. How could we improve healthcare literacy in rural Georgia? Well, most certainly, Representative Jackson, we need more education. It begins with that, making sure that we have more programs to be able to meet individuals. Rural Georgia has such a lack of healthcare. We have how many counties in the state of Georgia? With more than half of them do not have access to healthcare providers. We've had so many hospital closings. And so it puts a lot more of the onus on our individual members, your constituents, to be able to care for themselves. But without the knowledge base to do so, they're kind of left on their own. And so making sure that we have more programs that are culturally appropriate, that's another very important part of it. You have to be able to speak to people on a level and in a language that they can understand. My family is West Indian. You're trying to get me to lose weight, and you give me something that says I have to eat hummus and grapes. I'm not interested in that. I want you to tell me how much oxtails can I eat? Is it one? Am I putting a drop of gravy on the rice and peas? Should I take out the peas? Like, speak to me the way that I can understand. If you really want me to be compliant, so socially and culturally appropriate, and using the information, providing information that is really going to make a difference, because there's so many things that are available, but it really doesn't get to the root. Dr. Francis, Ms. King, what do you think about that?
I would agree. I think, of course, there are deserts there. One of the ways we can possibly combat that is by using community health workers. I think sometimes we often overlook the people in the community that also work with healthcare organizations. Community health workers are residents, generally are residents of that community, and they understand the community itself, and they also understand the healthcare system. They can provide the informations to prospective patients on a one-on-one. They can provide it in an appropriate language, help them with any needed paperwork or resources, or help them find that. So it's unfortunate that we are cutting public health funding, we're cutting healthcare funding, because one way to implement the programs is by using the residents of that community to then go out and spread the message and help the health literacy. So that's one way I think that we could address that.
Absolutely. And I do believe in the same, I echo the same sentiments, because at Wellstar, we try to do that. We don't have community health workers as the label states, but we have people within our system, in our department, that are able to communicate with, for instance, we have bilingual with promoters, we call them, working within the system and helping to deliver our programs. And those programs are more, they are more appropriately delivered when you have representatives from the community who could deliver the product, explain it in the way the community can understand, maybe layman's terminology, and have buy-in, because communities don't want people who don't look like them or who are not familiar with the language come into the community to tell them what to do. They'd much rather have a resident from the community encourage them and share with them and educate them, because they are more trusted. So this is something we really need to focus on. I know Georgia has not gotten over the hurdle of the community health worker. I know it's something that a lot of organizations are working towards, to have a really an organized program where people can be certified in the work and they can actually utilize them. Since we do have a shortage of nurses, we expect to continue to have that shortage maybe until the world ends. So we can utilize community health workers who really, they don't have to be educated to the to the far end of the earth. They could be just a regular high school graduate that's trained. They don't have to have a master's degree. They don't have to have a doctorate. I think we could make a lot of use of those individuals if we just put our minds to it. If Georgia would just settle down and agree to have these people, and I'm going to be speaking to that at some point in time, but if they can do that, I think that would benefit the community significantly.
Yeah.
I'd like to transition into our next question. And this question goes for Mrs. King. The topic is preventative care, chronic diseases, and vaccine equity. What locally tailored strategies have you determined to be successful in overcoming vaccine hesitancy and increasing participation in preventative health screenings across Georgia?
So thank you for the question. I think this should be approached using various strategies. So I'll just mention two here. So one would be to partner with trusted organizations. You want to partner with those organizations, so that be it schools, places of worship, local health departments, colleges, any institutions within those communities that you're trying to serve. You want to partner with them to build trust about the initiative that you're trying to implement. And it also improves the credibility of that initiative. These organizations, they understand the community. They are well respected by the community. And so understanding the cultural, maybe the linguistic and the social needs of their community, they can tell you what's going to work, what isn't going to work, how to best recruit these individuals, how to get them engaged and stay engaged with all these preventative health screenings. And I think partnering with trusted organizations also allows for expanded reach. Again, they know the community better than you. They can tell you which preventative health screenings will work and how to go about doing that. And it also allows for resource sharing. The second thing, and sometimes it's often overlooked, I love mobile health clinics. Like, I think they are the best thing since sliced bread. And so
Yes.
these are fully equipped medical clinics on wheels, and they offer a variety of services depending on, the institution that's providing it. So they can do testing and screening, they can do health education, counseling, referrals, linkages to care. And why I love mobile health clinics is because they're often able to reduce the barriers that potential patients feel, right? So they are able to go into non-traditional settings during non-traditional times. So that reduces the barriers in terms of transportations. Instead of having us depend on the patient to get somewhere, they're going into that community, right? They are able to offer these services at non-traditional times. The 9 to 5 doesn't work for everyone. Sometimes people are working, sometimes people are working multiple jobs. So being able to offer these services at non-traditional times, maybe on the weekends, potentially can increase the participation rate in that preventative health screening. I also think that mobile health clinics are great because you can combine not only the healthcare aspect, like the physical well-being, you can combine some of the other social needs that that person may be facing. So combining some sort of preventative health screening with, the need for insurance information, housing placement, WIC, things like that. So it provides a one-stop shop for that individual, caring not only for their physical needs, but also their social and emotional well-being as well.
Fantastic. Dr. Francis?
Yes, I would piggyback a little bit on what Ms. King had to share, because I do believe that leveraging trusted messengers within the community, such as faith-based leaders, barbers, salons, beauty salons, and so on, these people could be local advocates for whatever we're trying to deliver. At Wellstar, we partner with the Congregation Health Network and to launch and promote community health events. So oftentimes the church is our launching pad, and they help to propel some of our programs forward. We even at Wellstar, we even have a platform where educational and best practice information are shared with congregations throughout the Wellstar footprint. So people can go and download evidence-based trusted information, CDC and all these organizations. The churches can download this information, and when they have their service, they can use some of the information in the health nuggets. I totally believe in mobile clinics like Miss King just mentioned. We actually have, well, we don't have a mobile clinic, but we do utilize mobile vans to go into the community when we have, for instance, a mobile market where we provide foods to community residents that have problems with access, or they just live in food desert. But we also utilize that time to share other information. We may talk about vaccine, we talk about blood pressure, we talk about strokes, we talk about diabetes. So whatever the flavor of the month is in the nation, we try to incorporate that into those into that space. We actually, when we did a lot of COVID vaccination, we would pair clinics we would pair ourselves with Cobb Douglas Public Health to have health events in the communities. They will do the vaccines, we would do other health events. During COVID, of course, we did all the vaccinations, but providing materials in languages that people and formats that they can understand is critical. And here's the reason why we engage bilingual employees to assist in serving the community residents, because that is very critical. And we are actually encourage people to share real stories to help humanize health decisions via social media, probably a medical minute. We have several medical minutes throughout the Wellstar system with our various programs, and we publish blogs to get people engaged and to have them thinking and participating, because we really have to remember that trust is built in the community, not the clinic, not the clinic. So we must meet people where they are if we want them to, what we quote unquote call compliant with what we're trying to offer them. There must be buy-in, and we have to have buy-in from the community. And of course, we have to be trusted so they can buy into whatever it is we're trying to promote.
Dr. Francis, I have to say, when I first met you, you came armed with a plethora of this and that in every language. I mean, and I was just so impressed with Wellstar's commitment to making sure that every community was given the tools necessary to be able to strive and thrive. So I just want to say thank you for that and for sharing. You know, it's not just that Wellstar has these opportunities, but that it is being broadcast widely so people understand that they are there and it is available for you to take advantage of. And I just want to pick up on something that you said when it comes to stories and hearing the voices of the individuals that are affected. And I know all too well the power of a story, a testimonial, because when I go to the Capitol and I get to speak to State Representative Derek Jackson, the individuals that are making the laws, that's what sways them because they want to hear the voices and they want to know what their constituents want. Representative Jackson, are you available?
Hi, Dr. Nelson. I believe they have me pulled in now.
It's so fantastic to have you with us. I mean, how lucky are we? I think that any opportunity that I get to hear from you, because you have all the words and know all the things when it comes to healthcare. So please share your insights. How important is it to hear the voices of the community.
Well, first off, Dr. Nelson, it's great to be with you all and this highly esteemed panel. It's very important. The reason why it's so important is the very first question that healthcare practitioners ask the patient. How are you doing? Where is the pain? And then you all listen. And I think we as legislators must do the same thing, Dr. Nelson. We have to ask the question of our constituents. How are they doing? And the response will vary from zip code to zip code, area code to area code. Earlier, you all certainly piqued my interest with the literacy piece because my mother, which was a nurse for 40 years before she transitioned from this world, as you certainly know my story, but my mother was a nurse for 40 years. And I can only recall some of the invaluable nuggets that she taught me and my siblings. And that was, when you know better, you do better. And that's the reason why I'm so grateful that you all are having this conversation around literacy. And one of my questions that I asked in the queue, which I think is going to make your job so hard and difficult now, and that is, what is the remedy of dealing with misinformation and disinformation when it's coming from the federal government? Because our constituents, Dr. Nelson, they're hearing the information from the HHS, how they don't believe in vaccines, how they don't believe in doctors, and all these things, which I think is creating a state of confusion for you all that have gone to school for many decades, and you do this work out of love and compassion. And that's my question. What is the remedy? How do we deal with this climate that we in when you hear the federal government that is stripping away billions of dollars from research, billions of dollars of literacy information, and as a state level, I don't know how to combat that for 159 counties, 537 cities. And some of these counties, as your listening audience should know, but some counties, 12 in particular, do not have a healthcare practitioner at all. And so when something may happen, they don't even know who to go to get the information. They don't even know who to respond to. And we know time is of the essence. And so when they need that health care practitioner, like an OBGYN or a nurse or a PA, it's not even available in their city or in their county. And so I would love for your panelists to help a lawmaker like me that's running for governor of Georgia. And I ask this not because I'm running for governor, but I ask it because it's a problem that we need to solve. It's a problem that continues to grow over these last 24 years, because we don't need women dying simply trying to give birth to children. We don't need children dying simply to sustain life after they're born. And we have a huge crisis on our hands, and the federal government has already told us, Dr. Nelson, they're not interested in helping Georgians. They're not interested in helping CDC and NIH. They're not interested. So because the federal government is not interested, we need to have the state government to step up and say, we're going to do our part to provide the resources, incentivize doctors, nurses, PAs, and the likes to go in these healthcare deserts, I call them, so that way we can make sure we can prevent death, we can help mitigate this situation that should be preventable.
That was definitely a mouthful, Representative Jackson.
You know
But
me.
oh, I know. And John, you have your hand up, but I just want
Yeah, Dr.
to
Nelson.
jump in.
Sure, I just wanted to jump in. I think it's a great segue because, what we're dealing with now is really the elephant in the room. So, as a result of HR1, depending on if you want to call it the big beautiful bill or the big ugly bill, what we're facing here in Georgia is that by the end of 2026, we have approximately 160,000 Georgians who will no longer have access to health care. And by 2030, 2032, 2034, we're looking at an estimated number of about 600,000 Georgians. So when we're talking about preventative health care, I mean, this is really what we're talking about right now. I mean, this is really at the forefront. Am I correct? And if you and your colleagues could elaborate on that, how do we address this crisis that we know that's coming in the next year and a half?
So this is Michelle Nelson's personal take. And John, you know me. I'm from Brooklyn, New York. I got a big mouth. So to me, you can give your misinformation, but the one thing that I have is I come armed with the truth and the facts. Facts don't lie. And the ability to have a louder voice than the ones that are currently talking. This is what we have to do. When I'm speaking to my students, I always share with them that we are in the middle of our own healthcare civil rights movement. These things are cyclical throughout our lifetime. We see things get better, we see them get worse. There's an uprising of the people who take to the streets and just won't take it anymore. And you hear the louder voices and people who get out and they want to fight. This is where healthcare providers find themselves. And yes, we may talk about, nurses and physicians and PAs, but when it comes to this issue, dealing with misinformation, there is no nurses, doctors, PAs, dogs, cats, bunnies, blue, red. It's all of us together, making sure that we are using evidence-based knowledge. That is the well from which we draw. And we speak loudly and get that information out. This is what we must do. This is the mandate. So not only that we're educating, but we are really turbocharging that education that we're giving. And we're out in the streets and we're out in schools and we're out everywhere. That's one thing about me, John. I'm always tired. But why?
Yep.
Because I'm everywhere.
That's right.
I'm everywhere.
That's right.
Just like you. We are out and about. The job is not done at the courthouse. It's not done under the Gold Dome. It's not done at my university. The job is done out in the street where the people are. Go to them. Dr. Francis talked about, working with the churches. The Black church is the bedrock of our society. You got to take, how does it go? Take the mountain to Muhammad. You got to take the information to them. Don't wait for them to come to you because they don't know where they're going. We're not just competing with loud voices. We're competing with all kinds of different platforms. It could be social media. It could be podcasts. It could be this. It could be that. We have to be involved in every single opportunity, platform, show up. If there's something going on in the community for kids, geriatric patients, you've got to be there.
That's right.
And it can't just be me.
That's right.
Because too many times I show up, I'm the only one. We have got to mobilize our communities to say that they also need to show up for themselves because they also have a mandate, just like the last poll question.
That's right.
How responsible are you for your own health? Everybody said that they're responsible, but you're also responsible for going out and spreading the truth if you know you've got it. So that's Dr. Nelson's prescription.
I agree.
The rest of the panelists, we're not getting to all of our questions tonight. We're going into something
And
else.
the last point
Forget
before I turn
about
it
them questions. We're doing truth talking here tonight.
yes, we are.
Dr.
No, that's
Francis,
right.
Ms.
Dr.
King,
Francis,
what say you?
absolutely.
One of the things I wholeheartedly believe in is our power is in our hands and at the ballot boxes. And though while some people may say that their votes don't matter, every single one matters. And I believe that, as a race of people, we're often disadvantaged and we don't have the resources to do what we would like to do. But I believe that the legislators that are, especially the local legislators, they have to encourage their constituents, have town hall meetings in the various communities and bring people in to educate the constituents so they can make informed decisions, so they have evidence-based information, facts, and not fables or fiction. Because with everyone on social media now, you don't know if what you read or see or hear is really accurate. You have to do your own deep dive to determine the accuracy. And not everyone has the ability or the time to do that deep dive. So I believe wholeheartedly in the town hall meetings from the legislatures, like Representative Jackson is going to be running for governor. You need to come out into the communities with your other legislatures and engage the community. Tell them what you're going to do. Share with them the facts of what's really taking place. So when they leave and they go to the ballot box, they could vote for people that are going to promote the agenda, promote the things that are beneficial to them, because they have the facts at their fingertips, and then they can utilize their time and decision to vote for whoever is going to represent them. So yes, we have to be more actively engaged, but for those that are unable to be actively engaged, we got to take the mountain to Methuselah, and we cannot wait for the mountain to come to Methuselah. We gotta take him there.
Right. And
Okay,
Dr.
see, it's
Francis,
Methuselah. I
if
got
could,
my whole Bible scriptures wrong.
that's
The mountain to Methuselah.
that's right. That's
right.
right.
We know exactly what you meant.
That's right. If I can just add to that,
Yes.
this is not a civic engagement conversation, but everything is so linked. This is a nonpartisan organization, so we're not endorsing any political anything, but for the purposes of this discussion, to add to what Dr. Francis was saying, that what's happening right now is a direct result of the choice that voters made or did make, for lack of a better word. And so, it has added to the health crisis that had already been existing prior to last November's election. And so, I am imploring listeners today not only to certainly take control of your own health, but also to understand that public policy is driven by civic engagement. We have to be civically engaged. We have to be civically engaged. We're not going to tell you who to vote for. That's not our job to do, and that's not what we're supposed to do here at the Urban League, but we can empower you. So make sure that you know what the issues are, who's supporting, keeping hospitals open or Medicare and Medicaid, and making sure that we have enough physicians, that are being trained, and we have enough young people going into the professions, that health schools are being properly funded. That's up to you as a citizen. And I can't say it enough that public policy is driven by the participation of its citizens, particularly in this country. So, Dr. Francis, as my grandmother would say, you hit the nail on the head.
Squarely.
Squarely.
Okay, so I'm supposed to be asking these questions. Let's get back to some questions. The next question goes to Dr. Francis, and this is one of my favorites because it's centered around social determinants of health. So, Dr. Francis, the Next question focuses on health equity, social determinants of health, and social justice. What policies, in your opinion, should Georgia implement to improve access to trusted community-based healthcare providers who can bridge the gap in medical mistrust and misinformation?
This is a great question, and thank you for it. I am actively engaged in promoting health equity as part of my daily responsibilities. So I understand the community needs very, very well. And here are a few things that I would consider. Expanding funding for community health workers programs with sustainable reimbursement. We touched on that a little bit earlier. Incentivizing mobile health clinics, telehealth hubs, and faith-based outreach. Of course, we're engaged with them. Diversifying healthcare workforce pipelines. Patients trust providers who share their own cultural and linguistic backgrounds. We all know that for a fact. I mean, when I lived up north, I didn't have much choice about some of the physicians that I engaged. In the south, I can pick and choose whoever I want to see. Partner with HBCUs is another thing. Nursing schools and public health programs to train providers in cultural humility. This is something that some of our providers need to really focus on. And I believe Wellstar is doing a great job, and pardon me for bringing up Wellstar, that's where I work. But Wellstar is doing a great job by we have business resource groups that are geared towards diversity, equity, and inclusion. I know those are obscene words right now, but we try to engage our employees in groups that sort of resonate with their cultural background, so they feel comfortable sharing their needs or their wants, their concerns. They feel comfortable sharing with those groups. And another thing I would think about making trust building a measurable outcome in public health funding. So when people apply for public health funding, they ought to demonstrate certain characteristics, and we ought to look for and engage certain things. Because I believe that, we often speak of lack of providers, but we just don't need more providers. We need providers who are trusted, visible, and invested in communities they serve. This is something we all need to chew on. Investing, because we talk about a shortage of providers in the rural communities, and we have to make practicing in those communities attractive enough to bring new graduate residents, new physicians, bring them out to these areas. Maybe we can promise or, paying off their student loans, for instance, like they did way back yonder, paying off their student loans if they serve in underserved communities with low access to healthcare, low access to food. We have to make it attractive enough for providers to want to go into those communities, leaving the heartstrings out of it, but to want, because they have to eat, they have to feed their families, they have to repay their loans, so they just can't work in a charitable environment forever. So we have to make it attractive enough for them to go to these rural areas to practice and feel that they're not just contributing to society, but they're making a difference in the lives of the communities they serve.
Phenomenal response. Ms. King.
Yeah, I'll just echo Dr. Francis's sentiments, excuse me. So I mentioned earlier that I went into public health before becoming a nurse, and my ultimate goal for becoming a nurse was to be a public health nurse. So to go into the communities to serve the people that I care about the most. When I moved down here, I was just shocked by the rate of public health nurses, and I think it's well underfunded, and I think it's a real disservice to the communities. I think if we're really serious about improving the lives of those who need it the most. We have to fund the programs. First of all, fund the programs to get people who look like us, live where we live, to become providers themselves, and secondly, pay us a livable wage. I would love nothing more than to work at a public health clinic and do the work that I think is well needed and that I love, but I can't do that because of the rate of pay. So we need to incentivize people like me who want to go into the community and work hand in hand with the community.
That is absolutely correct. And, you know, different, more creative ways to incentivize individuals to go into rural areas is absolutely necessary. And, you know, individuals who want to become physicians and want to go and work in rural areas shouldn't have to make those hard choices of, I'm going to be saddled with debt for decades because I want to go back and practice in the small town that I come from. There's so much money in this country. Something is very wrong when we cannot put more resources towards being able to fund the education of individuals who are dedicating their time, their lives to serving others. And so I really am a big proponent of taking a look at that. No one should have to lose their ability to also live a life. The pursuit of happiness should not be compromised because you want to live a life of service to others. I have a policy question for you as well, Ms. King. And if I could transition into that. This particular question centers on policy advocacy, sustainability, and accountability. What I want to know is how can we ensure that Georgia's state health education campaigns are culturally competent and targeted effectively to address the unique concerns of underrepresented communities? We did say earlier we need culturally appropriate and specific care. How can we accomplish that?
Yeah, that's a question. So one of the ways that I would implore us to do that is to involve the community in the design, the testing, the development, and the delivery of any of the health education messages that we're putting together. And oftentimes we have external groups forcing messages onto community groups, and that's not what they want to hear. It doesn't resonate with them. So when you're involving the community in the development and the delivery of the health education message, it makes the campaign more authentic, it makes it more relatable, and it makes the community not only likely to just listen to that campaign, but to actually act on the message. So for example, if we're trying to increase the vaccination rate amongst African American women, adult women, we want to hear their voices. We want to know what's going to work for them, what's not going to work, and how to implement that message. And so they will not only just hear the message and say, yeah, that's a great idea. They're actually going to go and get their vaccines, and that's going to increase the vaccination uptake for that group. I think involving the community in all steps of developing the message helps to tailor the message, right? And so you want the message that you're devising for this health education campaign to reflect the local language and the slang. You want it to reflect the cultural beliefs, the norms, preferred communication style, the preferred communication messages. And so when you're doing that, to prevent miscommunication. There are plenty of examples and recently about miscommunication, putting out a message and it not resonating with the community of focus. I think when you're involving the community, it helps to strengthen the long-term impact of that message. When you involve the community, it tends to allow that message to be more sustainable. And it does lay the groundwork for ongoing partnerships, not only with this particular health education campaign, but for future campaigns that may be. And it also helps to improve the community, helps improve community overall uptake of the particular health education campaign. On the flip side, I think it's also important to hire and train a diverse workforce, right? So we have the community providing that message, but we also need people who understand that message to develop that campaign. And so you need the people who have that shared experience, shared lived experience, to then add their public health expertise or their behavioral expertise or their communication expertise to help translate what the community provided into a strategically designed health education campaign. I think when you're using individuals who come from the same background to devise these campaigns, it helps to bridge that gap that may exist between the community and the entity trying to implement the public health campaign, right? And so these staff can act as cultural brokers. They can ensure that the community message is not only well informed, but it's evidence-based, like aligned with evidence-based, because they have that expertise. And I think when you're using and training hired diverse work staff, it helps to avoid the dilution of critical information that the community may have provided. So sometimes the community is providing a message, but if you don't understand what the actual message is, the campaign turns out flat and it doesn't get the results that you want.
I totally agree with this. Because if our programs are not culturally competent, they're not reaching the people who need it most. So it's imperative that we are using community-based focus group to shape our messaging. That messaging must be shaped by people in the community, because requiring cultural competence in what we do is just maybe the tip of the iceberg. But what I alluded to earlier, and I spoke to that, I believe that requiring cultural competence in all state-funded campaign is a must. People should not be receiving any state-funded monies if they're not able to explicitly demonstrate what they are going to be addressing. So that is a must. And I think another way we can benefit, we know that people like you and me, we love the radio, we love television, so we have to partner with ethnic social media outlets. That's another way we can make a difference. Local radio station, faith-based institutions. We know everybody listen to 103 and all those stations, 1380. We need to get our messaging out in those areas, because we have to be able to measure the effectiveness of our messaging. And of course, we cannot track what we cannot measure. So we have to be able to track and measure to be able to determine that behaviors have been changed. We're able to impact the community. We're able to make a difference, because we don't know we're able to make a difference if we cannot track what we're doing. And of course, you cannot measure what you don't track. So I just wanted to add that.
Dr. Francis, I greatly agree with you. In the last campaign, I was out and about canvassing and just being nosy, speaking to people out in the streets. And I remember one day after coming from an event where I had to speak, I went to a well-known restaurant downtown, and as I sat waiting, I was sitting at the bar, waiting for my food to be prepared. And as usual, I just started speaking to a lot of the young people around me and asking them, did you go vote? And, what is it you're into? And so many of them were engaged in things that we don't, and part of it is our age group as well. They are engaged in so many things that I didn't even know what they were talking about. And most certainly after the election, it became very plain that dissemination of information did not go through the normal channels that we're accustomed to. We sit and we watch CNN and Fox and MSNBC, and we may dibble and dabble in a little Facebook. not young people. They're not on Facebook. They're not watching what we watch. They're
True.
listening to podcasts.
Yes.
Huh? Like I didn't even know what some of the people that they had mentioned. I had never heard of these people. And so this is why it is so important that we are out and about in the community, asking questions, strike up a conversation, because we were blindsided. We had no idea what was going on. And so we have to hopefully have learned a very warm lesson on making sure that we're diverse in the way that we are the outreach to individuals across the spectrum, from children. We need to be speaking to them too. They're future voters, and trust me, they are smart as a whip and have their own thought process. It needs to start young. Get them in the pipeline, engage in their civic duty, that they understand that they themselves have a responsibility to care for themselves, but also care for their communities, and to be the concerned and informed and engaged voter of tomorrow. These are the things that we must attend to, and to understand all the new things that are out there that we're not paying attention to. We have to. You got to have your ear to the ground. And the only way you can do that is being out and about with the people. We cannot sit, we're big time academics and Dr. this and Dr. that. We have to be out in the street. None of that matters to them. You have to be out with the people, engaged, and making sure that the information that they need to have that's culturally appropriate is also being disseminated in the way that they are going to receive it.
Dr. Nelson, I'm going to have to connect you with my AVP, who is a Brooklynite and a community advocate, and she's just like you. So I may have to make the connection.
Just like me, shy, and
she's not shy.
that never lands well. I do
Two
try
of you
that.
together
No one
will
ever
rock the
goes
world.
for it. A shy introvert. Everyone looks at me like a crazy. One thing that we haven't been doing, because we're having this juicy conversation, we haven't been doing our poll questions. Let's do 2 poll questions right now. Kennedy, put up 1, and then let's transition to the next one. How confident are you in your ability to navigate the healthcare system? Can you advocate for yourself? You feel like you can speak to your doctor? Can you stand up for yourself?
The poll's not letting me answer.
Because you're a
You're not
panelist.
allowed.
You're a panelist. You
Oh,
can't be a panelist and a not panelist too, Representative Jackson. You're one of us now. You can't answer.
okay.
Kennedy, can we bounce to the next one? Oh, this is kind of split.
Mhm.
And definitely something that we need to address as we go back to our various corners and our practices and offices. Some people are saying that they're not feeling very confident about the ability to navigate the system. And that is so very much needed. Even as a healthcare provider, when I go to urgent care or I have to go to emergency room or whatever, sometimes I sit and I say to myself, if I didn't have the knowledge base that I have, if I didn't speak the language, how could I show up somewhere and advocate for myself? It's hard enough when you have the knowledge. So we have to make sure as providers, as advocates, um, community leaders, whatever we are arming our individuals and communities that we serve with the information that they need to feel confident that they can advocate for themselves when they are in the healthcare space and setting. Representative Jackson.
I thank you, Dr. Nelson. I think the other part, though, if you ask that same polling question to those over the age of 75, they will probably say, I can't navigate it at all. When you have nearly $1 trillion removed out of the Medicare system, for example, that means you have less number of call centers available. You have the less number of physical offices available to where they can walk into a facility and get their questions answered. That is also the population over the age of 75 probably may not navigate the technologies or app of today. And I know this to be true because I'm taking care of my 88-year-old aunt. And so if I was not her caregiver, she will probably, her days will be numbered. It will be accelerated because she would not, one, have the ability to navigate this highly advanced technological world. And when you're dealing with memory loss or early stages of the big D, um, you you will find yourself with a federal government that is not, again, it's not interested or have the appetite to making sure that the citizens, regardless of their age, regardless of their domicile, that they can navigate the system. And when you have, and as a retired military officer, I hear this all the time from our veterans. It's hard for them to navigate, for example, the VA system, simply try to get health care. They don't understand that they're placed on a waiting list for 6, 7, 8 months, especially when they may not make it right to their appointment. They may transition or the situation may become worse, only to be told by a doctor, well, we wish we would have seen you 5 months ago. That's not what a patient needs to hear.
Right.
When the system is so cumbersome, so complicated, to where we're leaving a significant population who have already paved the way, who've already paid their debt into this system, which they should be entitled to. And so your polling question is an excellent question, but I guarantee you, as we continue to talk about this topic, which is a very rich topic for us to talk about, once you get outside of 285 and move further away from Atlanta, the response will be very grim.
Agreed. John, I know that you have something to say, but as you are preparing your remark, um, Kennedy, please put up the next poll question. So as people are listening to John, they can address this. How confident in your healthcare provider's ability to keep you healthy? Do you trust your providers? John?
Yeah, Dr. Nelson, I just wanted to piggyback on what Representative Jackson was saying. As you know, I had a very serious health crisis a few years ago where I was dealing with neurologists and all types of specialties. And I've thought to myself, I'm a college educated, I'm a pretty smart person, but I had a hard time, quite frankly, advocating for myself. it was beyond my general practitioner. I'm dealing with now, specialists and highly, specialized professionals, and I needed someone to really to advocate for me. I wasn't in a position, quite frankly, at that time to advocate for myself. And so, particularly for men, I can only speak for Black men. I don't know if it's just how we're wired as men, but I think a lot of men in particular have a hard time advocating for themselves. And quite frankly, sometimes, depending on the physician that you engage with, you might feel not adequate to be able to talk to a physician in a way that's helpful for yourself. So you really, again, hit the nail, squarely on the head regarding that. We have to learn, we have to teach each other how to be our advocates. We can't just rely on a doctor. Some doctors are more engaged than others. I'm intentional. I have a Black female doctor who it keeps me on my toes, and I did that intentionally because she's going to tell me, John, what are the stats? Let me see the numbers. What's going on? How are you feeling? She's going to take time to sit down and talk to me about what's really going on. And in the absence of that, it can be a matter of literally life and death. So thank you all for bringing that to everyone's attention.
Oh, a lot of people are somewhat confident. No one is very confident in their providers. We've got some work to do. We've got work to do here. And as Representative Jackson said, that if you were outside of 285, this is probably going to look a totally different. But John, I want to go back to something that you said. My husband does not go to the doctor without me. Not for me to know. And I know his doctor is, like the young people say, sick of me when he sees me coming. Because I have not come to be told or to be lectured. I'm a very active participant, not only in my healthcare plan, what the plan is for me, but what your plan is for my husband. I must be a part of that plan. And I go with the labs that I want to see drawn, the tests that I want to see done. And I need you to take, I'm here with him. You didn't look at the skin on his back. How come you didn't look at let me show you this, let me show you that.
Real.
He's there for me to show the doctor what it is that I want the doctor to see.
That's real. That's for real.
He doesn't know, as
No.
brilliant as my husband is, he doesn't know. And so I think it is very important, as Representative Jackson said, at family members, your neighbor,
Yes. Yep.
someone at the church,
I agree.
you got to have a buddy.
You better.
Particularly if the person is older, they don't know. Trying to watch my mother-in-law navigate Facebook or to get on a Zoom call with her little friends, you might as well butt up your popcorn and bring a glass of wine, because it's going to be a whole comedy show for at least 30 minutes.
That's
With
right.
her looking into the camera like a fisheye lens. It's just Mamma Mia. But
It's real.
by the grace of God, that's going to be us.
Yeah.
And please make sure, ladies, that you are going with your partners. Men, you're going with your partners. Be engaged. If you can't go with them, like you send your kid to school with a note pinned on their lapel. Send the questions written down and tell them, don't come home without these answers. And question them when they come back. And guess what? If you don't like them questions, call the doctor.
Or change your doctor.
Sir.
How about them apples? Or change your doctor.
That's
Yes.
right. Like my
Yes.
mama says, my money doesn't have any names on it.
That's right.
There's no name on it.
That's right. It's not personal. It's business. It's your life.
No,
That's right.
no. And so please make sure that you are with a doctor, that the way that they are treating you, the care plan that you are in agreement with it, you have a right as a patient.
Yes.
You don't have to just take what they tell you. If you're getting a bad vibe, move on.
Mhm.
Move on. Dr. Francis says she has a plethora of people that she can bounce around to. Bounce hither, thither, and yon. Don't stay stuck.
Yeah.
Get with someone who makes you feel good. You know that person has got your back. That is very important. And please make sure that you are engaged and understand what is happening under your roof. Because
Yes,
if you don't ask questions, it's going to become your problem. Yes, Dr.
Yeah.
Francis, is that so?
absolutely. Absolutely. Sometimes I'm not sure if I should say amen when you say something or
I'll say it.
but
Amen.
you're preaching.
Listen, you climb down, I climb up. I climb
Right.
down, you climb up. This is the way that
Amen.
has to go. What happened with the last poll question, Kennedy? Did we do that? Yeah, we did. You know
Yes.
what? Give me one more before the time runs out.
Can I
Can
add? I just wanted to add, in addition to that, doctors, providers are sometimes really busy people, and sometimes they're just oblivious to what you need. So lean into their nurse or their MA. Those can be your best advocates when you're working with a care provider. I know myself that there were times that I would go into a room after the doctor had been there, and the patient had no idea what they were talking about. And so it was my responsibility. I took it as my responsibility to explain to them what's happening and just the different options that they had. And I would go back out to the doctor, like, you did a terrible job. They don't understand anything that's going on. So if you have the right assistant, medical assistant, nurse, LPN with that provider, you can lean into them and they will advocate for you.
And Janelle, if I can just add to that very quickly, we'll come back to this in terms of cultural competency. That is real. That is real. You know, I had a relative, a very close relative of mine who said she wasn't happy with her physician. And I had asked a couple of questions, and I'm like, well, I don't know if that particular physician was able to really to relate to her in a way that she needed to do that. And I said, listen, that's important that you have to make sure that that the person that you're interfacing with can certainly understand, yourself and some of the issues that face, particularly, our community, which, as you know, Black women have special um, health concerns sometimes. So the cultural competency piece is very, very important. I can't stress that too enough. That
Yeah.
is very key.
Mhm, mhm. Now, I'm not saying because you're a Black woman or you're a Black man, yet your provider has to be a Black woman.
No, not at all.
It has to be that the person is skilled
Yes,
and their ability to relate to you.
that's right.
How do you feel when you leave there?
That's
Do
right.
you feel heard? Do you feel seen? Do you feel that this person cares about you? That they rushed you in and rushed you out? Did the people take their socks off? I can't tell you how many times I go to a visit and they don't even know if I've got toes. My toes could be sitting in a purse. How come you didn't take my clothes off and see what's going on?
Right.
I gladly rip them off and show you because I want to make sure that there's nothing going on that I can't see.
That's right.
So please make sure that if the doctor or the nurse practitioner, the PA, the whatever, does not ask, can I, they're listening to your lungs. They're right there. They can look at the skin on your back.
Amen.
Okay, make sure that you're advocating for yourself. You're paying them. They're not doing some type of community service. You're paying them good money. So if I'm your provider as a nurse practitioner, feel free to say to me, Michelle Nelson, I need you. Can you draw this lab for me? Can you do this? My grandbaby said you should have been doing blah, blah, blah. You're not going to hurt my feelings. You're not going to hurt my feelings. In fact, I'm going to be grateful because I'm not going to overlook something
Right.
that, like you said earlier, 5 months ago, if I had looked at it, it could have saved your life. Okay. Is everybody, I'm hoping everybody responds to this. What's the response there, Kennedy? Very knowledgeable.
Good.
I'm happy to see that. But most importantly, there's someone who says they're not very knowledgeable. And just like with my students, I tell them all the time, I'm very interested in everybody that gets an A, but I'm more so concerned in someone who's got a C. That's the person that I need to focus on. So please make sure that the next time you go to your, whoever said they're not very knowledgeable, the next time you go to your provider's office, that you are asking them, when do I get, if you're a male, when am I getting a testicular exam? When should my prostate exam happen? Should I be doing something at home myself? If you're a female, are you doing your self breast exams? How often should I have a mammogram? Those things keep changing up and down. When was the last time you had a pelvic exam? But most importantly, before you ask all of that, I'm asking you, when was the last time you went to see a doctor? If you have not gone for your well visit, which should happen at least once a year, it's time to go to the doctor. It's time to go. So please make sure that you're getting down to the doctor's office and that you're asking the pertinent questions and that you're not feeling that you are embarrassing yourself. There are no stupid questions when you go to the doctor's office. Ask away. Let's move on to the next question. We're running out of time, so we got time for one more question. And that question is going to go to Dr. Francis and to Ms. King. Representative Jackson had brought up the utility of technology and how it can act as a barrier. So this is a question that focuses on technology, innovation, and digital health solutions. How can Georgia state and local governments fund and expand digital health literacy programs? Are they even needed to combat misinformation and improve community trust in medical science? Dr. Francis, quick thoughts on
Yeah,
this, and then Ms. King.
yes, that's a very, very good question. I was hoping you would touch on it because we are living in an age, in a digital age, and we're moving further into the digital space. However, we're leaving a lot of our residents behind, especially the elderly, the elderly. So I would recommend that Georgia, the state of Georgia, local governments invest in creating grants for digital health training at libraries and senior centers and community hubs to educate those that are not in a position to have that maybe in the homes. Expand rural broadband access. There's a dire need throughout rural Georgia because some people can be engaged in telehealth, but they don't have broadband, so they can't access. Co-create culturally relevant digital content with local influencers because the boots on the ground would always have an impact. Integrate technology training into like WIC programs and SNAP and Medicaid orientation because we really need to leverage what already exists. Offer multilingual, user-friendly patient portals and telehealth tools so people can access. Because for us, as a result of our 2019 Community Health Needs Assessment, the Center for Health Equity created what we call CTPs, Community Transformation Program, to bridge an identified gap between technology and equity, and we say affectionately equity. So non-governmental organizations are encouraged to apply for grants of up to 10K that will allow them to use technology to expand access to healthcare and to address social determinants of health. Because digital literacy is the new social determinant of health. Without it, communities are left behind in the information gap. So I know we at times, so I'd give Ms. Janelle the time to add her comments.
Yeah, I agree wholeheartedly, Dr. Francis. That's where most young people are getting their health information from now, right? They're not going to the news or reading newspaper. They're getting the information from technology. So we as in Georgia have to do a better job of investing in that. All health systems are moving to become more technologically based. So that's where we should be investing our resources to make sure that nobody is left behind.
Absolutely.
Absolutely correct. We have, I think, one more polling question. Kennedy? Yes. What is the biggest barrier to healthcare in your community? Please choose one. What is your biggest barrier? Kennedy, responses, please. Cost of care. In fact, it's all over. Every last one of these are significant barriers to people being able to access healthcare and to keep themselves healthy. And so every last one of these responses requires significant focus and solutions. And so I implore everyone on this call, no matter what your role is, okay, you're the provider, you're the patient, you're the consumer, you're the researcher, whatever you are, please make sure that you are engaged and you're doing your due diligence, as we are all responsible for ourselves and each other to be able to combat all of these barriers. We're all needed. I just want to really take the time to thank our special guests this evening, Dr. Francis, Ms. King, and Representative Jackson, who just happened to fall in as a panelist because he's always got something to say. And we're just always so grateful to have you with us. We have had a wonderful, rousing conversation this evening. And actually, we've had Ms. Shelli-Ann McKenzie jump on, who's one of our partners for the roundtable, this webinar representing HHCP. I saw her for a minute and then didn't see her. Oh, there she
There
is.
she is.
There she is.
Miss McKenzie, can
Miss
you give
Shelli-Ann.
us 2 words as we're out of time? We
You're on
no,
mute.
we can't hear you. Your thing is off.
I hate that I missed this one. I can't wait to listen in. Thank you, Janelle. Thank you, Dr. Francis. We really appreciate you. And Derek Jackson, we appreciate you as always. John, thank you so much. We're honored to hold the quarterly with the Urban League. And I'm doing the Lord's work tonight here at the hospital.
You do that.
And keeping everyone alive, right? That's what we're doing. But thank you so much. We look forward to all the work that we have to do together. We just have to keep collaborating and just get the stuff done. There's a lot in front of us,
Yes.
and we just need to get it done.
Thank you.
Absolutely. John, take us out.
Sure.
And
Absolutely.
let me say a special thank you to our wonderful Kennedy Smith. Kennedy, thank you so much.
Oh, yes,
Always
Kennedy.
pulling us together. Thank
Yeah,
you.
we could not do this without you.
No, we couldn't.
Absolutely not.
We could not. Again, Dr. Nelson, thank you for this incredibly insightful and powerful presentation. I also want to extend my deepest gratitude to all of our distinguished panelists and guests with us today, including my good friend Shelli-Ann McKenzie. And to you, our audience, thank you for joining us and for your commitment to building a healthier community. We'd also like to give special thanks again to our executive producer, Kennedy Smith, and to our Urban League president, Nancy Flake Johnson, for making all of this possible. On behalf of the Urban League of Greater Atlanta, thank you for being a part of this vital conversation. We look forward to seeing you at our next session in this ongoing health series. On behalf of us all, have a good evening and good night.
Yeah.
Take care.
Thank you.
Thank you.
Good night, everybody.
Good night.
Bye-bye.
Good night. Good night.